Hello, everybody. This is my case study, the write-up for Sophia James. I have attached my actual write-up, and I will present to you on each different topic. So if you want to follow along with the presentation, the discussion goes relatively close with the visual slides. So on this slide, I'm going to present the patient overview and the primary assessment findings for Sophia James, a 28-year-old transgender female presenting with right-sided testicular pain and swelling for the past 3 days. Sophia describes the pain as dull, consistent, and localized to the right testicle, rating it as a 6 out of 10 in severity on a pain scale. She states that the discomfort does worsen with prolonged standing and physical activity. In addition to the pain, she does report dysuria, white urethral discharge. There's a mild fever and a malaise feeling. She denies any nausea, vomiting. There's no flank pain reported or any hematuria. A significant part of her social medical history does include practicing daily tucking for gender affirmation purposes, which may actually contribute to localized irritation or delayed recognition of the symptoms. She also does report an inconsistent, excuse me, inconsistent common condom use, and she does have a recent new sexual partner, excuse me. She has not had any STD screening in over 12 months. Her past medical history does include depression and gender affirming hormone therapy replacement with estrol and spironolactone. She has not undergone an oophorectomy or a vaginoplasty. She also has a documented allergy to penicillin that is known to cause hives. On physical examination, Sophia appears mildly uncomfortable, but she is alert and oriented and engaged during her visit. Her temperature was elevated at 100.5 degrees Fahrenheit, while the remainder of her vital signs were in fact stable. The GU examination revealed right-sided scrotal swelling and tenderness localized to the epididymitis. There's white, non-bloody urethral discharge was expressed on palpation, and no inguinal lymphopathy was present. The cardiac, respiratory, and abdominal examinations were otherwise remarkable. Overall, Sophia's presentation is most consistent with acute epididymitis, likely secondary to a sexually transmitted infection such as gonorrhea or chlamydia. She does have several risk factors that can include the risk for this specific diagnosis, which include her reported inconsistent condom use, her reported recently new sexual partner, her infrequent STI screenings, and possible irritation from that prolonged tucking practices. Okay. And this next slide, as you can see, does go through the list of differential diagnoses. The most likely diagnosis, there's recommended testing and the treatment. So Sophia James' primary differential diagnoses, primary differential diagnosis is acute epididymitis. This diagnosis is strongly supported by that gradual onset of the unilateral, which is very important here, scrotal pain, epididymitis, tenderness, dysuria, and the urethral discharge. And again, that low-grade fever that she's reported. My second differential diagnosis is testicular torsion, though this is very unlikely because the pain developed gradually and the urinary symptoms are present. It does remain as a medical emergency that must be ruled out due to the risk of the ischemia and the risk of losing a a testicle. The third differential diagnosis is otitis. It can present with a scrotal pain and swelling, but the tenderness being localized specifically to the epididymitis takes epididymitis the most likely diagnosis. The workup here, as you can see, would include a urinalysis along with a urine culture. And we will do nucleic acid and amplification testing and AAT, and that would be used specifically to test for that gonorrhea or that chlamydia that we believe may be causing this. It's best practice to also get HIV and syphilis screening since she reports she has not had a recent STI screening as she does have a new partner. And scrotal ultrasound if the torsion cannot be excluded completely. It's stating this could be a medical emergency, so we have to do everything we can because of the presenting symptoms to rule this out. And then lastly, I'll discuss with you a treatment plan that I came up with for Sophia. I would initiate an empirical antibiotic therapy following the CDC recommendations. And if you follow based on what the CDC recommends for this specific treatment, it would include cephalosporin 500 milligrams intramuscularly once. And we're also going to go ahead and pair that with doxycycline. We're going to do 100 milligrams orally twice daily for 10 days. Sophia does in fact report a penicillin allergy that causes hives, so further assessment of an allergy severity would be necessary before administering any cyclosporids. We would discuss supportive management for Sophia, and this would include NSAIDs for pain and inflammation. We would actually teach Sophia to do scrotal elevation. We're going to teach her to rest, hydrate, and remain temporarily abstinent from any sexual activity until these symptoms are cleared, fully resolved, and the treatment is in fact complete. An important social determinant of health that plays a role into this case is ensuring access to culturally competent and gender care affirming healthcare, because Sophia does in fact present as a transgender patient. And we're going to use inclusive communication with her, using her preferred pronouns, and provide affirming sexual health education are essential in building that trust and improving health outcomes specifically for transgender patients. That is my presentation on Sophia. I hope you enjoyed it, and this is just my reference slide. Thank you very much.